Holder. I'm actually the Director of Conferences and Conventions for Treatment Management Behavioral Health, and she's actually our Corporate Medical Officer. So a quick overview of who we are. So quickly, we have facilities, substance abuse and alcoholism in Arizona, California, and Florida. We're fully licensed in all the states that we operate, and we're Joint Commission accredited. If you notice at the bottom of our who, it's also the top of our why, which is our mission is to help you uncover your story, discover the real you, and recover your treatment life. Basically, at Treatment Behavioral Health, we want your time with us to be the last treatment episode you'll ever need. But as it kind of finalizes to the why of us or who we are, it's the fact that we have Dr. B, which you'll see in a quick second. I actually label her, she's basically our Steve Jobs. It's kind of how I label her as such. So Dr. Andrea Grubb Barthwell is the founder and CEO of Two Dreams, a comprehensive wellness center for the treatment of alcoholism and substance use disorders. She's the founder and chief executive officer of the Washington-based global healthcare and policy consult firm EM Global LLC. She also served as deputy director for demand reduction in the Office of National Drug Control Policy under President George W. Bush. In 2003, she received the Betty Ford Award from the Association of Medical Education and Research in Substance Abuse. In 1997, her peers named her one of the best doctors in America, and she's a proud mother of 3. So at this point, I introduce you to Dr. Barthwell.
The objectives today are to describe some of the therapeutic approaches that create the underlying contemporary view of substance use disorder, particularly opioid use disorder. That's a big issue. To evaluate them and really the cause for why we're responding at every community. We're in a, as the interventionists will say, they're in a race with the patient to the undertaker. We're trying to get them before they end up with the undertaker. We're looking at evaluating the impact of existing responses on outcomes in substance use disorder, particularly those of opioid use disorder, and to demonstrate the knowledge of emerging treatments for and treatment targets in substance use disorders, particularly opioid use disorders. So I'm going to look at our current understanding of current substance use disorders. I'm going to talk about the current treatment approaches, and then look at where we get our existing responses from either psychosocial therapies, medication therapies, or combination therapies of medication and psychosocial. If you were in the opening plenary last night, you heard Mike Barnes, who was my confidential counsel at ONDCP. He's an attorney that knows so much about the biomedical aspects of addictions. He's like an anomaly in the legal field. But he said that there's policies that are looking for encouraging, because the use of MAT was so difficult to embrace, medication-assisted treatment was so difficult to embrace, the government started putting out mandates around giving people access to it in drug courts, was maybe the first one that you will recall. I worked with Pam Rodriguez. I saw her in here in Task in Illinois to educate all of her case managers way back in the late 90s. And we taught them all about the usefulness of medication-assisted treatment in the management of their patients. And they were one of the first organizations working in conjunction with the criminal justice system that would not require that you come off your medication-assisted treatment to graduate in a positive way from their programming. So this isn't new that people who have opioid use disorders, when selected on a biomedical basis for maintenance therapies, can do better than if they are not given an option to use it. But what was really particularly disturbing about last night is that they're going to require that in advance of other therapies. And Alan Leshner, who was the head of NIDA back in the mid-90s, used to say, talk therapy is the foundation of addiction therapy, and medication therapy works best on a foundation of talk therapy. In contrast to mental health, where medication therapy provides the foundation for talk therapy. We actually are being so reactive to the fact that people have been denied access to medication-assisted therapy that we have forgotten the paradigm in which it works with addiction. And so we're going to talk about that a little bit. And then I'm going to, if we have time, talk about some emerging treatments that are more esoteric. If I don't have time, I'll give you the slides and you can look at them yourself. So in understanding substance use disorders, you have to understand the work that we've done to look at initiation. And what Alan Leshner also taught us was that drug use is a preventable behavior, but addiction is a fundamental yet treatable disease of the brain. And 40 years of outcome studies by NIDA has shown us that some treatment is better than none, more is better than less, but treatment is best if it's driven by assessment, buttressed with case management, and completed with follow-up care in the community. So there's nothing magic about 28 days of treatment. What is magic is deciding what treatment do you predict will work best for the patient in front of you, so actually assessing them and matching them to a treatment, and then continuing to evaluate them over time, their response to treatment. It's like a dose response. If I put you on penicillin in the emergency department for what I presume is a strep throat, and 48 hours later, your fever's not down and you're not feeling 80% better, I probably chose the wrong medication or I had a bad diagnosis. And so I'm, in medical care, there's a constant evaluation of the dose and your response to it. And medications are selected for, you have the drug for the diagnosis at the right duration and the right dose. And if you don't get all of that right, you may not get the outcome that you need. Likewise for treatment, you have to make some guess based upon an analysis is what the person is going to be responsive to, and then you have to look to see if they are. And if they're not responsive to it, what you don't get to say is, they're just not ready for it. Because the patient that I prescribed penicillin for that has a fever 2 days later, I would never say that that person wasn't ready to get over the strep throat. It's my responsibility as my medical mentor, my psychiatric mentor, Dr. Edsonay, taught me. It's my job to continue to pursue answers down every domain until I find the right one that is going to enable, there's that awful word enable the patient to respond to the therapy and get better. Because people don't really want to stay sick. They don't want to stay sick and die. That's not, we're going to talk about why that seems to be a motivator in a minute, but people are not choosing to stay sick and die. So in order to understand substance use disorders, we need to understand initiation, and initiation is something that people have volitional control over. So it is appropriate to just say no if you've not initiated, but once you have ever used, your brain is fundamentally changed. Bob DuPont tells us in the Hijacking the Brain book that he wrote that any exposure fundamentally changes the brain in the way it responds to all the messages about drugs in the community and to drugs. Maintenance is another process. Then there's interruption, and your choice of therapies to interrupt drug using is important. And then there's the whole phenomenon of reinstatement and relapse. So here's the first take-home message. If somebody goes to jail and stops using, and then they go out, let's assume you can't get drugs in jail, right? For a minute, in my fantasy world, right? And then you're released and you use drugs again. Is that a relapse? It's reinstatement, right? Now suppose it's a reinstatement, it's a continuation of the underlying disease state that you weren't able to act on while you were in an environment where you didn't have access to chemicals. Let's say you went into a 28-day treatment program at one of the finest names in the country and didn't use during that 28 days, and you went home and you used again. Is that a relapse? Nope. Why is that not a relapse? Same as being, because there are people who will stand on their head for 28 days. They can avoid using for 28 days, knowing that as soon as you open the door and they're back out on their own, they're going to use again. So how do I know whether it's a reinstatement or a relapse after a treatment episode? Well, if a person acknowledges addiction, commits to recovery, and reduces or eliminates inducement to use, and I can prove that that happened as a response to being locked up in jail or developing an insight and developing skills and reducing symptomatology and putting themselves in a new place of structure and support, if they acknowledge addiction, commit to recovery, and reduce and eliminate inducements to use, and have a period of non-using in that new state, and then they use, that is a relapse. So we throw this term relapse around when in fact what we're seeing a lot of is continued use. It's not a reinstatement or a resumption of the disease. It's just a continuation of drug use because the underlying state has not changed. Nothing has changed that would predict that the person wouldn't use. So let's look at the neural basis of addiction. So in the early stages, dopamine is extremely important to setting up this disease. And we know that Relapse is triggered by reinforcing substances and or stress. So dopamine is important in setting up your stress cascade. Seeking a dopamine release in response to a behavior is part and parcel of using. So dopamine is critical for the acute reward and is critical for the initiation of the substance use disorder more than almost any other substance. Now, why is that? Well, dopamine is released from reward areas of the brain in response to us doing the things that are life-sustaining or life-promoting. So when we eat a good meal, there's dopamine release. When we drink when thirsty, there's dopamine release. When we engage in intercourse, bad or good intercourse, there's dopamine release. Why are you smiling, Leslie? Why pick on Leslie? Bad or good intercourse, there's some dopamine release. Maybe not as much if it's not good, but there's dopamine release. When and because that also promotes perpetuation of the species. So the things that we do that promote our own individual life or perpetuation of the species is associated with the reward. Why? Because that brain has to engage in those behaviors that promotes the continuation of your life or life of the species. So if we didn't have a reward, we might not engage in the behavior of sex. You have to put a reward on the end of that. If you really were to dissect the behavior out, you really would need a reward on the end of that to do that. So the dopamine is released in response to the things that we have to do. It's a reward for doing the things that we have to do to perpetuate our life or the continuation of the species. And it gets released in minute amounts in the brain. That dopamine is important for our sense of feeling at peace or in harmony with the world. When people who don't have enough dopamine floating around in their brain is put on things that promote the release of dopamine or block the reuptake of dopamine or other neurotransmitters that interact with that system. So it's very important for us to have dopamine released in order to condition us to engage in the behaviors that promote or sustain life. When you engage in a drug-using behavior or get 3 little cherries in Las Vegas and get the ding, ding, ding reward at your one-armed bandit, there's also a release of dopamine that far eclipses the amount of dopamine that is released in your brain when you eat a good meal or engage in some of the other behaviors. So dopamine is important as a motivation to engage in behaviors repeatedly that are associated with, here's the connection, that are associated with maintaining our life or perpetuating the life of the species. Now, the primary behavioral pathology in drug dependence is this overpowering motivational strength to engage in the behaviors that release the dopamine. It's an overpowering motivational strength of that, and a decreased ability to control the desire to obtain drugs. So there's a feedback loop from the executive control center of the brain, which matures last in adolescence, which is why it's important for us to delay the onset of drug use in adolescence until there's maturational control of the executive center. The executive center, sort of tones down the drive to engage in those things that release dopamine, so that you don't engage in intercourse 6 times a day. You don't, eat. There's a imbalance in that system when you overeat, and there's, so that there's an executive control center to tone down the drive there. But in drug use, where drug use is the thing that releases that reward for the behavior, there's a decreased, lost ability to control the desire to obtain drugs. And understanding the cellular and the circuitry underpinnings of addiction allow us to see where we can interfere with those pathways to create novel things that will disrupt the development of addiction or disrupt the maintenance of addiction. Now, it's allowing us to predict pharmacological or pharmacotherapeutic targets, but we don't have targets for everything that we know we could upset. And sometimes when you think you can interfere with something, you're going to get a side effect from the use of that chemical that makes it impossible to take that chemical to market. So you all know that marijuana causes the munchies, right? So you would predict that if you interfered with a system that is set off by taking exogenous THC, you could interfere with appetite and maybe develop a medicine that would help people turn off their appetite and lose weight. And there actually was a medication that was all queued up for that, but it also, since it turned off that pleasure connection, it led to people feeling like they should commit suicide or demonstrate suicidality. So when it came time to approve the medicine, I'm so hot under these lights, when it came time to approve the medicine couldn't get on the market. It was effective in helping people lose weight, but it was a vanity drug. The FDA considered it a vanity drug, so they wouldn't approve putting it on the market because people could commit suicide taking it. And losing weight, even though being obese is very life-threatening, it was a risk-benefit analysis that was conducted by the study group to approve it, and they recommended not approving it because the side effect associated with blocking that system had such severe consequences. So while we know a lot of places where we can manipulate brain chemistry with chemicals, we may not want to use all of those things. Likewise, with marijuana, people say that THC is very good for a number of things, but the amount that you take when you smoke is so big in comparison to the amount of THC-like neurochemicals that get released by your brain that the risk associated with those huge amounts that you put in there are probably not worth the benefit that you can gain from them. That's a whole nother discussion.